Worcester Acute Hospitals NHS Trust, and this is a board meeting in public of the Worcestershire Acute Hospitals NHS Trust. We are live on YouTube at the moment, so welcome everybody. Just some introductions. Can I welcome Sue Sinclair, who is with us. She's recently appointed Associate Non-Exec from a clinical background. We're really looking forward to working with you, Sue, and thanks for joining the board. I'm sure hopefully you'll find it interesting. And it's a new world, I know, for you, but I'm sure you'll be able to make a massive contribution to improving services for our patients. So thank you for that. I've got apologies from Colin and Richard. Colin, we knew about. Richard has got problems with, he's on a plane or something, I don't understand, but so he's unable at the last minute to join us. And can I welcome Andy Wicks, I think we've got here, who I think, let me just get, where's Vicky? Vicky, do you want to introduce him?
Yeah. So, hi everyone, thank you so much. I'd like to introduce Andy Wicks. Andy is the Chief Information Officer for University Hospitals Morecambe Bay, and that also covers the acute community services and GPIT. And Andy has been shadowing me at a Finance and Performance Committee, and is here today to shadow at Trust Board. And for those that remember, I actually hail from Lancashire, so Andy and I have worked together on and off probably for about 5 or 6 years, and he's a really great guy and valuable colleague. So welcome to Andy. Well,
welcome Andy. I hope you find it helpful. And can I finally introduce? Sorry, Justin's here. Justin, welcome, Justin. But particularly, can I welcome Rosie, together with baby Sky, who's going to do lead our patient story for us this morning. Just to explain to people, to make it clear, we always have either a patient or a staff story at the beginning of our board meetings. We think it's particularly important to do it in that way because, in a sense, it gives us direct feedback at the beginning of the board, and in a sense centres our focus on real issues that real patients and members of staff actually experience. We think it's important to set the tone for the board from that. Some of them are very positive, some are negative, some are a balance between the two, but it's very important, I think, that directly the board hears stories so that we can reflect on them, think about what we need to do to improve services to our patients, and to make sure that we're doing the best that we possibly can. So welcome, Rosie. Anna, are you going to lead this off?
I'll introduce it, Chair.
Oh, sorry.
Okay.
Sorry, Paula. Sorry.
Thank you.
Paula.
So welcome, Rosie and Sky. As we've discussed in many boards around the Continuity of Carer programme and transforming maternity services, I wanted to bring a story that was around continuity of carer, and Rosie is about to tell us her lovely journey to a home birth and beyond. And baby Sky, I think, is now on the floor, but she can pick her up anytime she wants and show us to her. So over to you, Rosie, for your story, and thank you.
Yeah, thank you very much, Paula. So yeah, just to confirm, baby Sky is on the floor deliberately. It wasn't there wasn't an accident before the meeting began. So yeah, as I was just saying, I've kind of made a few notes, so do forgive kind of my looking away from the camera, just to kind of look through these. But yeah, so to introduce myself, my name is Rosie, and I've got a 3-month-old daughter, Sky, who I'll probably bring on in a second once I've kind of got through these notes. But to give some kind of context, then I always wanted children, so I'm telling a story about the birth of my first daughter, my only child, but I have always wanted children. But a combination of factors, things like how labour is depicted in films and experiences that I've kind of seen friends and family have that weren't necessarily the most positive experiences of labour, made me kind of really pretty scared of the whole process. So there was always a kind of juxtaposition of wanting children, then having to go through a process that really quite scared me quite a lot. So as a first-time mum, I kind of just assumed that I would deliver in hospital. That was kind of what I thought everyone really did, especially the first time. And to be honest, I was really keen to secure an elective C-section. So because of those kind of fears I had and about the unknowns and things that could go wrong, and I kind of felt like if I could secure an elective C-section, at least I knew what the risks were. I could make an informed decision based on something that seemed to be more set in stone than the unknowns of labour. So when I first met my midwife Sharon, I asked about having an elective C-section. That was really the road I wanted to go down, and she was really nice, and she said that I could sort of go down that road of discussions and talk to necessary people if I wanted to, but then she really kind of explained that labour didn't have to be something that to be feared, so it didn't have to be something that was scary. And then she went on to explain that I'd actually, because of my postcode, fallen into the continuity of care model, and that she was actually allocated to me as a midwife that would be consistent throughout my whole pregnancy and a little bit after my delivery as well, so that she was someone that I could really kind of make a connection with, and that the wider Opal team, which was the continuity of care team that I fell within, had 7 other midwives who would all be aware of me and my backstory and my preferences, so that even if Sharon, who'd been assigned to me, wasn't able to cover one of my appointments or even the delivery itself, it would be somebody who was part of that team who would know about me. I'd have come up in discussions leading into my delivery, and so it would be somebody that was familiar with me, and I potentially would be familiar with them as well if I'd sort of crossed paths with them on any of my appointments. And so even at that early stage, I think it was about 8 weeks or so. We had some scans early on and a few scares that meant that I kind of got seen a little bit earlier. But even at that early stage, that information was completely game changing for me. So I'm someone who really benefits from kind of making good connections with people, and a small number of people. I tend to have close friends and people that I'm close with. I don't have tons and tons of sort of, acquaintances that I see a lot of. I do value close relationships. And so knowing that this lovely lady who was sitting in front of me was telling me that she was actually going to be there throughout the whole process really made me feel secure and less alone. You kind of, especially with COVID, going into these appointments on my own. I've never gone through that before. And so having her being there and her saying that she was going to see me again really was changing for me. And then at this point as well, I also wanted to make an observation, and I've only kind of thought about this having gone back over the whole process in my mind. And to be clear at the start of this point, I want to make it very clear that I'm really lucky to be in a very happy, loving relationship. My partner's amazing. We've been together for 11 years. So this doesn't apply to me. But not every woman is as fortunate as that to be in a relationship that is as secure and caring. And so when you're kind of asked in those appointments whether or not you're in a safe environment and is there anything you need to disclose, and you're kind of offered the opportunity to ask for help if you are in a situation maybe where you're experiencing domestic violence, I think I'd have been far more likely to open up to Sharon as somebody who I was building a relationship with over a period of time than someone who I'd kind of just walked into a room and seen for the first time that day and who I probably would never see again. So although it didn't apply to me, I think that had I been in that situation, having someone I trusted would have really made a difference if that was something I did need to discuss. So just to go back then to my story, I'll get Sky up in a minute. Apart from those early appointments which were in hospital, the rest of them actually were at home. And so that really, again, kind of started to build this idea in my mind that I wasn't actually sick or ill, and that this was something that could take place outside of a hospital setting, and that people could come and it was something that happened in my own home, and that started to be an idea that kind of built in my mind. And it also meant that on my 16-week check, Hannah, who eventually ended up being involved in the delivery of Sky, I had met her at home for my 16-week checkup, and so when the time came and she ended up being at my delivery, I knew her and she knew my home, and it felt like natural to kind of welcome her into this very odd new environment of having a baby at home. So the other piece of the jigsaw was actually hypno birthing. So I did do a hypno birthing course where I learned about breathing techniques and read a lot of positive birth stories, which really started to kind of override. I'm going to get Sky out.
Yeah. Sweet puppy. I know. Come on, have a look.
There we go. So slightly more grumpy baby than was present a minute ago. But so this is Sky. So yeah, just to go back to kind of my story, that the hypnobirthing ability to kind of learn about the positive birth stories, they started to kind of push down all the negativity that I'd been exposed to throughout pretty much all my childhood and adolescence, to be honest. It's never really been something that was shown in films particularly positively. And so learning more about the role of oxytocin and how remaining positive and calm would really help with the process, and adrenaline being something that might slow it down, it made more and more sense in my mind that actually being at home where I feel safest and most happy would be most conducive to kind of the labour that I suppose everybody hopes for, and I completely acknowledge that there's so many things would have been out of my control that would have meant that I'd have go to hospital, but that would have been absolutely fine. So when I told Sharon that I'd kind of been thinking about home birth, she was really positive and explained exactly what support I would have. I knew that there'd be 2 midwives present for the sort of final part of the process, that if anything needed to be done that couldn't be done at home, I'd be taken to hospital straight away. It would have probably sort of a lower threshold of when I would need to go to hospital, because obviously I'm at home. And so that really kind of, again, started to reinforce this idea that it wasn't an illness, I didn't have to be in hospital, and that I really wanted to stay at home. So at that point, I genuinely started to look forward to it as a challenge rather than something to be scared of. And I really don't think I'd ever have said that before. Like I said, I wanted a C-section. I wanted to kind of go into a theatre and have everybody knew what was going on, and have all of the unknowns taken away. But I'm a cyclist. I'm into sport and things like that, and so it started to become in my mind more of something that I was kind of training for, and that I had a coach almost in Sharon that was going to help me prepare for this challenge, rather than something that was going to happen to me that was going to be really scary. So when the time finally came, my labour kind of developed over the course of a weekend. It kind of came and went, and so I'd been in contact with the whole team throughout that weekend through text, and whenever anybody came on duty at 8 o'clock, that was a sort of shift over time, someone new would text me and say they'd read my notes, that they were here for me if I needed anything, just to give them a call. So I kind of went around on my normal weekend, went for walks, went to a cafe, which is like my favourite thing to do. But knowing that at the other end of a line was someone that knew me and knew I was wanting to home birth, and I knew who they were, it really meant that I could kind of just relax through those contractions that were coming throughout the weekend, and not keep panicking about, what do I do now? Who do I call? Where do I go? And so it was, my daughter was delivered safely at home about 5 hours after the midwives, Hannah and Fiona, arrived. So on the day itself, my midwife, Sharon, was away, but knowing that I knew the rest of the team, that they knew me, it wasn't something that worried me. I mean, I'd have loved Sharon to be there because I'd obviously built this relationship, but it wasn't something that was weighing me down. I knew that I'd be confident no matter who arrived. And so although it was definitely hard work, it was an incredibly positive experience. I had 2 paracetamol and some gas and air and a birth ball in my sitting room. And I did have more pain relief that I had access to, but in the end I didn't really feel like I needed it. It was okay. And so in addition, the kind of ongoing support that I had after the delivery of Skye was also made easier for knowing the team. So being able to just welcome them again into my home, welcome them into my home, and ask any silly questions and have them check me over. The fact that I knew them, it felt like the most natural thing in the world to have them come and see me again. Oh, we're so close to the end. I know, it's okay. It's okay. I know. So, I'm so sorry.
Don't apologise, Rosie. Do not apologise.
So, the final thing really is I was really blessed to be cared for by this team. So I don't think I'd have had the confidence to follow my instinct to birth at home if I'd not been cared for by people that I knew. I'm so sorry. We're so close. I'm just gonna pop her on because then she'll be a little bit quieter for you. I know. Right, we'll be quiet. Nothing's on.
Don't rush it, Rosie. Just get her latched on. It's fine. There you go. Lovely.
Move.
I think this must be a first.
Well, it's marvellous.
Marvellous.
So yes, as I was saying, I really was blessed to be cared for by the team, and being taken under their wing, it felt like being given 8 sisters who were going to be looking after me and who genuinely had my best interests at heart. And I kind of went from wanting a C-section to being really excited about having a baby at home, which I feel like is two polar opposites of kind of a spectrum, really. They were always there to answer any questions, offer reassurance, and I really owe them a great debt, really, for making my first experience of birth so positive. And to finish, I really kind of feel like if it could be that the system of care to be extended to more areas, because it really is transformative for the women who are lucky enough to experience it. And it really was just a kind of postcode lottery that I ended up being cared for by the team and having the experience that I did. So that's me and baby Sky.
Thanks very much, Rosie. Thanks for that. A great story, and what a great outcome. So thank you for all of that. So any questions or comments that people want to make about all that story? Learned from it. Yes, I've got some here. Anita.
Thanks, Chair. Rosie, thank you so much for sharing that story, and just lovely, and it sounds like such a wonderful experience and such a great outcome. And I think the thing that really struck home to me, I mean, I've always thought that continuity of care has seemed like a good idea, but the fact that those relationships could really change your whole attitude to giving birth. And I mean, you made a really good point about people who perhaps didn't have a supportive home background, that having those relationships could be really helpful. I mean, it really does to me say that, you know, if we are serious about tackling health inequalities and disadvantaged patients and members of the community, this is a really powerful tool, and I can actually understand that, you know, depending on home circumstances, there are some people that, just like you, would find that relationship building that you experienced could be really valuable. So it's really it's a lovely story. Thank you so much for sharing and for bringing Sky along, and it's really just reassuring reiterating in my mind that this is a really powerful tool for us if we really want to make a difference to populations. Thank you.
Thanks. Okay, Simon Adams, Health Watch. Simon.
Yes, thank you, Rosie. And I'm not a member of the trust. I'm here to represent, Health Watch represents as the voice of the public. And I just wanted to thank you for what you've done, your contribution, and actually say how much more powerful, how you bring an NHS policy to life, I think, for patients, and give it meaning. And hopefully the trust will use your story to promote it, not only amongst the patients, but also amongst its own members of the midwifery teams, because I think it's been really powerful. And I think definitely a first, David. It's the first time I've seen a baby breastfed on YouTube.
Yeah, I tell you what, our breastfeeding's not been the easiest journey, so this is quite a surreal moment, to be honest.
I expect that's another story in itself, isn't it?
Yeah, it's a different day.
Yeah.
Fantastic. Okay, Simon Murphy.
Thanks, David, and thanks very much to Rosie and Sky. That was absolutely wonderful. I really just want to re-echo, I think, what's said. I mean, it's a very powerful example of continuity of care. For some of our staff in midwifery, this has been quite a challenge. It's been a very different way of approaching their profession. It's something that is being rolled out nationally, and we're at a bit of a vanguard here in Worcestershire, and we're very pleased with that. But we're bringing colleagues with us, and I think what you've just said to us here just speaks volumes for why it is the way to go forward. And that idea of having 8 sisters, a team, people you know, giving you that extra sense of comfort and trust is absolutely vital going through your first childbirth. So thank you so much, and in particular thank you for highlighting those who may be in a less fortunate situation than yourselves, because at times when a woman is in a situation of domestic abuse or violence, it can be very difficult to get professional help, and if continuity of carer can address that in its own way, then I think that's going to be a great thing. So thank you for highlighting that, because that certainly wasn't something that had occurred to me until you mentioned it. But great to have you on, and thank you so much again.
Okay, have I got anybody else? No. I mean, can I just, I mean, as you know, Rosie, this is, and I'm not putting this to you directly, but this is quite a controversial sort of policy, in the sense that there are people who would say to us, that's great, Rosie got a Rolls-Royce service, but what about the others who don't get access to it? What are you doing about that? And the other criticism that we would get, I think, on it is that those people who are left doing the other work feel overwhelmed by it. That somehow because you've got so many midwives looking after you, that there are less to look after them, sort of thing. And I just wonder, Paula or Justin, if you want to say something about those two issues.
So I'll start and I'll get Justine to chip in. So I absolutely agree with you. I think this is, it's a new way of working. It's caused some angst, as we know, and especially for people that work within the unit, within the hospital. And the reason I think when I heard Rosie's story was to bring this to the forefront was, there are good and not so good in both sort of ways of caring, and we've got to bring those to the forefront and all the positives that we need to take forward, and also to make sure that some of our midwives within the units are hearing Rosie's story and the positivity that comes out of that for the patient, our mom and the baby, is vital for our midwives on the unit to hear. So I think the more we hear of the positivity of the continuity of carer model, the more chance we have of making the transformation within maternity services come to fruition, really. But Justine, I didn't know whether you wanted to add anything else in.
Yeah, I think apologies that there's three of us huddled around one computer. We've just got a few Wi-Fi issues, so we're sharing. Just on the.
Who are the three of you, Justin? Who are the three of you?
So I'm here with Caitlin, who's our consultant midwife, and Scott Johnson is our maternity improvement advisor, who's just in the background here. So Scott's joining us today to be with us for our continuity of carer launch that Caitlin's leading on today. So this is all it feels like we've got a very theme today around continuity. Just picking up on your comment, Chair, about if midwives are providing continuity carer, it's taking midwives away from other women. I think sometimes what the teams and others may not realise is that they provide care for that group of women for the entirety of the pathway. So there isn't any removal of midwifery hours from the entire service. It's just how it's organised and delivered. And that's part of the teaching that we need to do to help the rest of the team understand how those midwifery hours are provided, if that makes sense.
Yeah. Okay, well, thanks for that, Justin. I'll give Rosie the final word. Well, almost the final word. I won't be able to help myself saying something after this, but I think Matthew wants to say something.
Yeah, thanks, Chair, and thanks, Rosie, for really powerful story and great news, and congratulations. My name's Matthew. I'm the Chief Executive of the Trust, but also I have another role as the what's called a Senior Responsible Officer, which is a bit of NHS jargon for having responsibility for maternity and neonatal services across Hereford and Worcestershire. And I think from a local maternity system perspective, we are absolutely committed, as this board is, to see the implementation of the national policy to move towards continuity of carer for all mums, partners and babies. And what we're trying to do is to bring the mother and family's voice more into the conversations we're having across the system. So I think it would be really helpful if we could perhaps continue a conversation with you offline here about helping our midwives and our obstetrics teams to really understand what this means for mums and babies and families as a really quite transformational change in the experience. So thank you, and I'm hoping we can continue this conversation, notwithstanding that you've got a busy time ahead, I'm sure. So thank you once again for joining us.
Thanks, Matthew. I mean, you have to be careful about these things, Rosie. If you get involved with us, we'll absolutely be there with you. Is there anything you finally want to say before I kind of wrap it up?
I guess really just again, just reiterate my thanks not only to the team but to the NHS as a whole. I think probably reiterating what the CLAPs might have been hoping to kind of do throughout the whole of the COVID pandemic, but just what all of you in all your different roles are doing is really, really incredible. And if I had ended up coming into hospital, I wouldn't have had any issues of whoever would have been looking after me. I would have had complete faith in. But I think just the impact of this model has been really, really positive for me. So thanks to everyone.
Thanks, Rosie, and thanks, Sky. As people know, I'm very much in favour of levelling up, and this is a goodie. I mean, in a sense, we want everyone to have the kind of experience that you've had, Rosie. And so as a board, we're absolutely committed to making that happen. And if you can help us in any way, that would be fantastic. But it's not mandatory. You don't have to. But thank you very much, Rosie, and thanks very much, Sky.
Thank you, Sky.
Thanks, Rosie.
Right then, let's move on. Always good to have a positive maternity story, isn't it, to start the discussion off. Okay, items. Any other business people want to say? Can I say that we will at 11 o'clock be marking 2 minutes silence? So I've got all sorts of people to organise it so that I don't miss it or we get carried away halfway through. But just so that people know, it's very important that as a board we recognise that. Declarations of interest. They're on the website. Is there anything in relation particularly to this meeting that people want to identify? Joe Newton?
Sorry, it wasn't a declaration of interest. I just wanted to note that the item H2 update has been withdrawn from the public meeting, Chair.
Well, I'll deal with that when I get to it. All right. Okay. Minutes of the previous meeting. Are they a reasonable reflection? There is one item for me that we missed in all of this, and that is on page 5, Chair's report. It says that an associate clinical NED had also been appointed and will chair the Quality Governance Committee. It is true that we appointed a clinical NED. I can now tell you that it's Sue Sinclair who's on the thing, but she won't be chairing the Quality Governance Committee, and I can't remember having said that at the meeting. So we just wanted to kind of expunge that bit, just to say clinical NED has been appointed. Thank you. Any other elements of the No? Okay, well, reasonable reflection. Thank you very much. Action log. Rebecca?
Yes, Chair, thank you. So there's updates as scheduled on the log. We've got the H2 item, as noted, has been deferred, and we'll deal with that later. The other items are due for later board meetings, so the updates are scheduled.
Okay, thank you very much. Let's move on to the Chief Executive's report.
Thank you, Chair. Morning, everybody. Few things to update colleagues on some important developments to share with you. First up, as a system, particularly at place level, we are on day 4 of a multi-agency event to seek to address the unacceptable levels of waiting times for patients that are attending hospital for emergency care, particularly those that are waiting too long on the back of an ambulance to be transferred into the department, and the long waiting times within the department, and also for those patients that are waiting a long time to be discharged home from hospital or into other settings of care. And obviously the significant pressure on staff within our organisation as a consequence of this. We started the week on Monday morning with a clinical risk summit. I called that as a way of framing what we expect to happen as a consequence of this multi-agency event. So there is no doubt in anybody's mind, particularly any leader across the place, the significant clinical risk that is experienced by patients in the current way of running services, and is managed by staff of the West Midlands Ambulance and the emergency departments of this organisation, and that risk is not shared equally across the system. And we wanted to make sure all leaders were clear on that, and the clinical leaders were able to set the tone very clearly for what has as is expected to be the outcomes of this 10-day multi-agency event. You can see there in the paper the number of organisations involved. You can see the intent. You can see that a control room has been put in place, and I think we can certainly cover later in the meeting when Paul is able to join us the progress so far. But I think it is fair to say that we have continued through the week to have high numbers of ambulance handover delays and high numbers of patients waiting to be discharged from hospital into community pathways and community beds. I will say though, Chair, yesterday the resilience of our clinical, operational and corporate teams was severely tested by two unrelated events, which led to the teams essentially having to focus on patient safety. Business continuity plans had to be put in place, and patients had to be moved from clinical areas to ensure that their care would continue to be safe. And I want to pay tribute to all of the staff involved who really were operating above and beyond in addressing those incidents, as I said, were unrelated and were not related directly to any errors that occurred within our organisation. There are follow-up actions currently underway to make sure that services are able to fully return to normal, and that's why we might have not full attendance, Chair, at the board for all of the board meeting this morning, as our leadership teams are making sure they're addressing the resolution of services both from an IT and an estates perspective. In terms of the rest of the report, I've referenced there the continuing work on developing our 3-year plan, year one of which will be the next fiscal year, and a lot of focus on that, albeit delayed by the significant operational challenges that we're dealing with, particularly with continuing increased numbers of patients with COVID, and therefore the impact of those. And as ever, take the opportunity to encourage those watching on YouTube to make sure that all of them and their families are vaccinated fully against COVID, because it has not gone away. The Virginia Mason partners, our continuous improvement partners, are on site this week, working with us now to get a sense of the culture of the organisation and start to do some co-design work with us around areas of particular focus. I've also referenced there, Chair, in my report, some updates on the integrated care system. The appointment of the Chief Executive and Chair roles. The Chief Executive role is complete, subject to the national sign-off, and Chair interviews are imminent. And we also had a session with system ICS leaders last week to discuss the membership of the Integrated Care Board. That, I think, was a successful conversation to ensure that appropriate representation and leadership from each of the key organisations, and I think was a testament to the fact that people can work together. I think the continuing challenge for us is working together to resolve putting patients first when under extreme pressure. The guidance on how the NHS People Plan should be implemented within integrated care systems is also included in the report there. And finally, just to note that our Chief Digital Officer, Vicky Lewis, We'll be moving on to pastures new in April, and we have commenced the recruitment process, or imminently about to commence the recruitment process to replace her. Of course, she is indeed irreplaceable, but we will very much do our best. I'll pause there, Chair. Happy to take any questions.
Thanks for that. Just on the Vicky Lewis thing, I'd add my view to all of that. There will be an opportunity, I think, to say goodbye to Vicky later on. But just two objectives that she has. She's got to stay till the end of March and sort all the things out that she's promised to sort out. And secondly, she's got to help us recruit somebody better than herself. But apart from that, a good luck. Thank you. Excellent. Let's. I've got some questions. I've got Julie Moore.
Okay, Matthew, thank you. Can we go back to the acute care bit? And I noted what you said about everyone coming together and everyone working nicely, but there's loads of patients awaiting discharge. What targets, what performance indicators and what accountabilities have been set to make sure that this is delivered and not just for this 10 days? I'm sorry for sounding like a stuck record and I keep going on about that, but we keep coming back to it. There's always patients who could be more appropriately cared for elsewhere, and yet they're still in hospital beds and we've still got ambulances queuing outside. And it's lovely that everyone's coming together and having nice meetings, but what's happening for patients now?
Yeah, really good point, Julie. There are targets that are set for the number of discharges from both the Alex and the Worcestershire Royal for each day, and specific targets for those patients that don't require care package support at home and for those that do. And so far this week, the first 2 days we did not meet those targets. The third day we were very close to it with 125 patients discharged yesterday. So this question of accountability is very much in the forefront of our mind, particularly as we had a meeting with the regional director, Dale Water, on Tuesday afternoon, where the specific focus of the discussion was what was happening in terms of optimising community care and community hospital bed stock, because there is a recognition that the acute trust is doing nearly everything that it can be, but it is a system response that's required. So this question of accountability, I think, is very much more at the forefront this week so far, Julie, than it perhaps has at times. But inevitably, there's still more work to do for people to understand the levels of clinical risk and the need for that to be shared. And that was, as I said earlier, the point of having the summit first thing on Monday morning. But as you and I both know, warm words are one thing, meaningful action is another, and that's what we're looking for this week.
Thanks, Matthew. I mean, I do think we need a bit of clarity here, and I don't know whether I should intervene on this in my role as interim chair of the ICS or as of this board, because it seems to me that we are pursuing through our integrated performance report the things that we're signing up to doing, but I've got no visibility of the things that other people have signed up to do and how they're doing against them. And I don't know whether I mean, there must be half a dozen figures there for us to, I mean, do I need to write to the chair of the Healthcare Trust and others to say, this is what our expectations of you are, and then make it absolutely crystal clear in a very public way, and then publicly measure them? Is that because it just seems to me that if we're not careful, we end up in a set of conversations behind not quite behind closed doors, because I don't think people are secretive about all of this, but this lack of public clarity and accountability, it slightly worries me.
Yeah, I mean, certainly, I mean, I referenced in my report the attendance at the Overview and Scrutiny Committee, which obviously is public scrutiny of what the range of organisations is doing, Chair. We have system-wide metrics that are monitored through the Home First Committee as part of the place governance arrangements in this new world order of integrated care systems. But I don't know, and that's not a pejorative statement. I don't know whether other organisations publicly report their performance against those agreed targets in the way that we do. And perhaps if you leave that with me, Chair, I'll first and foremost check with my chief executive colleagues as to whether they are indeed reporting in the same way that we do the metrics that are agreed within the place governance arrangements for urgent and emergency care performance. So we, of course, report ambulance handover delays on behalf of the system, but we don't report length of stay in community hospital beds, the number of pathway, the capacity and pathways that social care provide that are properly staffed, and so on and so forth. And those are metrics. To me,
that's important for us.
Indeed.
Not least of all for our deliberations, because it's quite hard to. A generality understood. About they're not delivering doesn't really.
Indeed.
Yeah, we need. Do you want to come back, Julie, on that or not? You've left your hand up.
No, I put it up again. It wasn't you, but it was on that point, so thank you.
Oh,
I mean, I was going to say I agree with your point that actually the only thing that's ever in the mind's eye of the system is the ambulance queues outside the hospital. And when we come and say they're not delivering, I don't know if they've missed it by 1 patient or 100 patients since we had 126 missing. And I think some more clarity and more sort of, I hate the word granularity, it always reminds me of a bag of sugar, but granularity around what is going on would be more helpful, so we could know if it's close and actually we've got a bigger problem, or actually maybe we need to start running something different to find a way of making sure that the acute beds are used for acute patients, because it's not just that we can't treat the acute patients, it's not good care for those patients who would be better treated elsewhere. And we all know what happens to people who are kept in hospital long after they need to be. So it's bad care for patients, both for those we've got and for those we can't get in. So I think to have more detail would be really helpful.
And Julie, just to provide some assurance, we do have that detail, but it isn't, as Chair said, visible to the public eye, and that's something we can certainly look at.
Okay, Simon.
Thanks very much, David, and it's very much echoing the conversation I had with Vic Allison yesterday, who is the Chief Executive of Malvern and Whichehaven District Councils, about which patients should be in hospitals and who shouldn't be, and the role of local government in that. But my question to Matthew is on the ICS update, and I note the progress is being made for the Integrated Care Board and numbers and roles being identified. Was everybody happy with that solution? Because I know there are a number of options there, and I think it's very important for such an important organisation that when it is set up, everybody says, yes, this is the right structure, and we're all happy with it, and we don't have people outside chipping away at it and perhaps undermining it. So it really is, was everybody happy with that structure that's being proposed now?
Thanks, Simon. Happy to give a view, and I'll also defer to Sir David for a view as well. I mean, my sense was that the conversation taking an hour and 20 minutes to reach consensus gave everybody the opportunity to give a view and to raise concerns and suggestions on the way forward. I think my take was that there was a level of recognition that there wasn't a perfect answer, a recognition that we shouldn't let perfect get in the way of good enough, a recognition that where we start may not be where we finish, and also a recognition that in the main all of the key partners remained involved in the conversation and remain involved in the structure that was suggested. I haven't, to be frank, spoken to more than 2 people after the session to test people's levels of comfort, but I've also not heard of any follow-up that has challenged what was concluded as yet, Simon. So happy to defer to Chair or Deputy Chair, Vice Chair, actually, who were both.
Yeah, what I would say about it was a very mature discussion, actually, and there are some views about it. So, for example, the option we took had 1 less primary care representative on the board than 1 or 2 of the other options. But at the end of the day, the successful option that was put forward by Ian Tate, who is the chair of the CCG, but also a GP from Herefordshire. So it wasn't it could have turned into a acute services versus something, but it didn't. People were, I think, very mature, and I think people recognised that what we didn't want was the lowest common denominator, a sort of thing where everybody's on everything. We didn't want to do that, but also a recognition that actually, as we get to understand how all this sort of stuff works and how it may be in 12, 18 months' time, we might want to revisit it. But I think it was very mature and certainly wasn't a difficult conversation for us to have. Is that reasonable, Anita? You were there? Yeah. Okay. Very good. Any other comments? Can I just ask, obviously there's been lots of publicity about making vaccinations mandatory for our staff. I just wonder, Matthew, whether apart from reading the newspapers, has there any been communication between the government and ourselves in all of this, and do we know what the expectations are? Because there were some caveats around it, clinical staff, frontline staff, all that. I just wondered whether we knew what all that meant, or are we waiting for proper guidance at some stage?
Yeah, so we are yet to receive guidance from the national team. We understand it is imminent, and there is in fact a meeting that's gone in the diary this afternoon, late afternoon, with Amanda Pritchard. I suspect that will be included in that discussion this afternoon. We can perhaps just check with Tina in a moment whether through the HR line there's been any discussion. We as an executive team have indeed discussed what we might do in taking the approach. We obviously, Tina and I have also met with staff side to discuss what that could look like, because obviously we want staff side trade union representation and support along the way. But until we receive the guidance, it is difficult to comment. Tina, did you want to add further to that?
Yes, please. So guidance is not due out until early December, we've been told, but there are 2 exemptions that are going to be included. So it would be exemptions based on medical grounds, but that would require either a GP or consultant certificate for medical exemption. And there may also be some exemption for people that don't come into contact with patients, but again, waiting further guidance on that. Our current take-up rates, we've got 90% of all of our colleagues have at least had 1 vaccine, and 85% with both. So we are profiling the 655 individuals that we just need to work with to understand why they haven't taken up the vaccine so far.
Okay, thanks. Matthew, come back.
Yeah, sorry, just to reference that, how helpful, should have let Tina go first, frankly, to know that guidance isn't coming to the beginning of December. That is, and it's worth us noting as a board, that is quite a long time for those staff that are worried about medical exemptions and their own situation to be worried about their jobs. And I think what we'll need to do is to go back, and Tina and I perhaps work out how we might lobby for some clarity, at least on what those medical exemptions might be, so we can calm some of our staff, because I have already had members of staff contacting me, asking me about the future of their jobs on the basis of their medical situation. It's not comfortable for me as Chief Executive not to be able to give some advice on this.
Okay, Wakar and then Julie.
Thank you, Chair. I just want to go back, Matthew, to the point that Julie raised, going back to Perfect 10. You talked about optimizing community care. Just in that group, I can't see any PCNs or primary care apart from obviously the community and healthcare. Is there a particular reason as to why you haven't involved them?
No, sorry, that's an omission. There were the meeting was chaired by a GP because it was a clinical summit, and we did have PCN representation there. So that's an error in the report, Wakar. We did have good representation for general practice, who are very engaged in trying to do what they can do whilst under significant demand themselves to help not to direct patients to ED unnecessarily.
Okay, Julie.
Thank you. Just back to vaccination for a bit, and Tina will probably tell me why we can't do this. But when I came to start at Worcester, I had to jump through endless hoops to prove that I had some kind of measles. I think it was measles. It was some childhood disease. And so you have to prove certain status for certain diseases. Now, I accept that this one's come along after people have started, but is it possible that for all future employment contracts, it is a condition of employment that people are vaccinated? Or are you going to tell me there's a reason why we can't do that? Because you have to do that for hepatitis B.
Yeah, so based on the national directive, yes, we can do that for new starters going forward. We can make that a requirement of their appointment, yes.
Can I come in, Chair?
Paula, yes.
So absolutely agree with you, Julie. And at the previous trust, I did do this for all new starters. If they couldn't prove it, they were to have it. If they didn't have it, we didn't employ them. And that was the MMR. So because we'd had a measles outbreak. So absolutely, Julie, it could be and will be hopefully a condition of employment. But we've done it with other vaccinations. We need to think about this in the rain for COVID as well.
Yeah. Okay. Well, obviously, I obviously support the government's decision here. I think it's the right decision. But it's all in the implementation here. We really do need to be sensitive, to work with our people, to talk to them, and to treat them in a humane and open way. Really, we don't want to, get into that place where you just have to have it, sort of thing. We need a conversation, and we've got some time to have those conversations, or to think about redeployment, or whatever it is that we need to do. But we need to do it in the most humane and supportive way that we can for our staff. Excellent. Thank you very much for that. Right, we've got the H2 update now, but I'm told that it's to be delayed to a future meeting. Slightly disappointing, this. I know that there are submissions that have to be made to the centre in all of this, and I don't want anything to go to the centre without the board approving it. So we'll no doubt have conversations later about that. Right, let's move on then to the NHS System Oversight Framework Segmentation. That sounds like a fantastic NHS title that no one else will be able to understand. Impenetrable title. Jo.
Thank you, Chair. And this really is both to note for the board, but also just to outline the background for the System Oversight Framework that you refer to, which will apply to all ICS provider trusts and the CCG. It outlines in there that actually we've been put into segment 3, which identifies that there are some significant areas where we need some support, but it will be drawn upon in an agreed way in terms of drawing a plan together. So the paper outlines some of the areas identified that we have already rehearsed this morning as part of the discussions that you can see in the paper, and the next steps are for us to work together to draw up that plan, because obviously the aim is to move from that level 3 to the level 2. So it's to note, Chair, but obviously happy to take any questions.
Okay, well, it kind of brings it home to you where we are in all of this. Although we do hope to make progress, we're still not completely out of the woods. The reassuring thing, I guess, from this letter is that there's nothing of surprise to us. All these things are on our agenda to be dealt with, but that doesn't make them any easier nor more significant for us to deliver. Okay, thanks. Simon.
Thanks, David. I wonder if Jo could comment on our other partners within the ICS. Are they in particular segments? Is that relevant to us? And also, does the ICS itself get a segmentation value?
That's a really good question. I don't know whether Matthew can help in terms of particularly the Health and Care Trust in terms of where they are, because I haven't got that to hand.
Yeah, Jo, as I understand it, the Hereford and Worcestershire Healthcare Trust is in segment 1.
Thanks. And the CCG, do we know? Because I'm assuming they would be included.
I'll follow up and just outside of the meeting give you the full breakdown for all the Hereford and Worcestershire partners.
Thank you very much.
Well, you've certainly wound me up now, Matthew, by telling me that. It kind of reflects the real dilemma that we have in this system and about where risk sits, really. But anyway, that's neither here nor there. Okay, well, we know we can focus on our own position here, which is not as good as it could be. All I would say, I can just assume then that all of these issues are dealt with as part of the H2 submission when we make it, just to confirm that would be the case. And secondly, that they would all be dealt with as part of the medium-term plan. You know, it seems to me that we need that consistency that we can make. Matthew?
Yes, Chair, just to confirm, the intention is to clearly make inroads into each of these areas. Particularly H2 submission is focused on the waiting list, which obviously is referenced in the bullet points 2 and 3, and not so much bullet points 5 and 6, and obviously it does include 7, but certainly our 3-year plan will include all of those elements and how we seek to move to resolve them over that period of time. So just to confirm, that will be the case.
Thank you. Okay, we note that report. Thank you for that. Board assurance framework, Rebecca.
Thank you, Chair. The paper sets out the ongoing development of the board assurance framework and then follows up the discussions that we had at the last board development session in respect of the developments of ICS in place. From that, we agreed the incorporation of a new risk to be incorporated on the framework, and the detail of that's appended. The report also outlines the ongoing development of the assurance framework, and the full detailed framework in its entirety will be presented to the board next month. The summary headline position is also appended. There is one risk that has reduced slightly as a result of other mitigations that have been put in place in rescoring, but it remains at a level 16. The final point for board is to review the process by which we have been updating the framework. Members will have seen the committee updates and reviews that have been taking place, and then to approve the incorporation of the new risk. So when you receive the full framework next month, that will be included. Thank you.
Thank you. My go-to person on this, Colin, is not here. But any other question? Any questions? Anita.
Yeah, thanks, Chair. Just to say, it's not mentioned in the paper, but Audit and Assurance Committee have also been through this, have reviewed this process, have reviewed the BAF format, have made a couple of recommendations, but essentially that's also, it's been through Audit and Assurance, and we were comfortable. Thanks.
Yep. Okay. Let's. So the particular issue that we've been asked to deal with is the risk 21, the new risk, which is to do with integrated care.
Yes, Chair, it's to do with integrated care, and it pulls together a series of the discussions that we've already had today in terms of the overall risk in terms of failing to capitalise on the benefits of integrated care and the opportunities that may be missed as a result of capitalising on those benefits, and that can be in respect of quality, patient experience, safety, or from a financial perspective. Very much follows upon the discussion that we had at the board development session, and also, as Anita said, an audit committee met this week on Tuesday. They also reviewed and endorsed that risk. The control measures are outlined within the paper, and those will be reviewed and updated as the arrangements develop. So it's one that we'll keep under constant review. I can't see that it will be staying static for any length of time.
Okay.
Just conscious of time.
Yeah, no, sorry. I'm watching the time. I'm trying to manage this so that we.
Feeling a very long minute.
Yeah, that we're working. I'm trying to get it right. So as a board, then we approve item the extra at risk, and we also recognise that we're going to have a much deeper discussion about the BAFTA future meeting. Okay, thank you very much. It's now 11 o'clock. Together with our colleagues in the hospitals and across the country, we'd like to make a 2-minute silence to remember those that have lost their lives in support of ourselves. Okay, thank you very much for that. It's an important element of both reflection but also solidarity with people, so thank you for doing that. Let's then move on to the next item of the agenda, which is it's provider collaboration, although sorry, I'm completely lost here because I've got a paper here headed collaboration at ICS level. I've got the wrong paper.
That's the correct
paper.
Is it the same thing?
Yes.
Okay, sorry, I'm confused. Go on then, over to you, Jo.
Thank you, Chair. So we have discussed ICS and some of the guidelines that have come out previously at board, and we've particularly been focusing on some of the place, and we talked earlier about the NHS body and constitution. This paper takes us to thinking about guidance around the provider collaborations that are required as we move towards a collaborative model of working rather than the competition PBR we've had in the past. Now, we know that as part of the clinical service strategy, we've always had a very pluralistic approach to our collaborative working, which is based on both working with our partners, patient choice and service delivery. What we are mandated to under the guidance, though, is to be formally part of a minimum of one collaboration. So this is both to just expand about the types of collaboration we're moving towards, but also to look for a recommendation that we formally approve an MOU with the SWIFT group, which is the South Warwickshire Foundation Trust Group, which is comprised of that trust plus George Eliot and the Wye Valley Trust, to become an associate member of the Improvement Collaborative. So the paper sort of unpacks those three different dimensions. It's a really positive step in terms of some of the working with an acute trust of a similar composition and view from a district general hospital perspective, but it's not the end of the journey, and we're having further discussions both as an ICS in terms of the collaborations, but the picture is becoming a little bit more complex with the different networks and alliances and mutual aid that is emerging post-COVID. So I think the paper should speak for itself, and obviously I'm happy to take any questions, Chair.
Thank you. Matthew, do you want to add anything?
Yeah, thanks, Chair. I think the relationships with neighbouring partners, providers, particularly those Wye Valley relationships, and also with the SWIFT group, as Joe says, I think are developing well, and also with colleagues at UHB, where we as board members will remember. We agreed quite close collaborations, clinical collaborations with colleagues there, and those discussions are back underway. The approach to the SWIFT group is very much about learning and sharing learning between organisations. That's as far as it goes. But I think given that we've started our partnership with the Virginia Mason Institute for the continuous improvement journey, we'll be able to share our learning, and they'll be able to share theirs, which is in a different context and model. So I'd certainly commend that to us as a step forward in provider collaboration.
Okay, Simon.
Thanks, David. It's just the point in the conclusion where we refer to pending a wider discussion with ICS provider colleagues. Does that imply that maybe our ICS colleagues wouldn't be happy with this? I mean, it seems like a good idea to me, but that the wording there was slightly open, as implied that maybe we might not go down this route if colleagues within the ICS didn't want us to.
Would you like me to come back on that one? Yes. So no, we've from Wye Valley perspective, we've already had those discussions, and we're already embarked in some of those conversations, as Matthew's outlined, and actually they're very interested in the Virginia Mason work we're doing, for example. I think it's more just as part of the ICS development plan, which when the paper was written hadn't quite come to fruition. There is just that bit around the exercising about what does the guidance and interpretation of mean across the ICS system. So we're having active conversations with both the ICS program team and Director of Strategy from the other partners, just to make sure we're consistent. So it's more a reference to making sure we've got that alignment and consistency, Simon. So nobody is against what we're proposing to do.
Okay, Anita.
Thanks, Chair. This associate membership of SWIFT, I mean, I've not heard of that before. Does it come with any kind of strings attached in terms of, or does it say anything about our longer term intentions towards the SWIFT group? That's it.
Yeah, thanks. Chair, shall I answer that? Because I've had a conversation. Anita, not at all. It is really just specific to sharing learnings and improvement approaches. There is nothing that ties them or ties us together beyond that. And it's worth also noting that the Coventry and Warwickshire team, I'm working closely with their chief executive and their improvement team as well. Because they have a Virginia Mason partnership, or they have had over the last 5 years. So I think we'll probably approach this from quite a pluralistic approach on improvement as well. Colleagues across the board table will know we've already linked up and partnered with the Leeds Teaching Hospitals Group on financial improvement. So in answer to the question, Anita, nothing beyond what's articulated at this point.
And sorry, could I just come back with the second part of it was really, I mean, you mentioned Cov and Warwick and others. I gather the legislation says one or more we have to be in. So does that mean that we have plans for further formal provider collaboratives that we want to put in place, and or do those relationships with Cov and Warwick or that we have already, would they already fit that bill? Thanks.
Joe, do you want to answer that?
Yeah, I mean, that's why I sort of put as a second recommendation whether we wanted to consider any other ones, because I think there is something here about trying to keep things simple, because actually there is almost a bit of where do you start and where do you stop with some of this, because we've got a multiplicity of MOUs and partnership relationships at both service and organisational level, and I think that's the bit of the discussion we probably need to just exercise a bit further. So Matthew's right, so UHB, UHCW, Gloucester, we're talking to, who are interested in talking. So, so it's an active conversation, but there isn't a proposition to have multiple MOUs just for the sake of it. I think sorry. I was just going to, I think the 3-year plan is going to be really helpful in steering and directing and confirming where those ought to be.
Okay, thanks, Joe. Hca.
Thanks, Chair. Joe, I'm just looking at the Appendix 1, which is the baseline submission. It's not your fault, because I would imagine this is what NHSEI have asked for, which is, collaboration type and description. But I just find that, there would be resource implication in terms of, certainly the human resource angle, but there is another box that's missing, which is return on investment, in terms of when we put that human resource in, what are we getting, what outcomes are we expecting, and that box is in there, in that appendix. Now, it's not, like I say, it's not your fault, because this is what for NHS E&I is a typical cultural thing that, they put forward. And to me, that's a problem, because it's like as if these provider collaboratives were just talking shops. But just focusing on what you're proposing here, which is the SWIFT associate membership, so what 1 or 2 outcomes are you expecting that would benefit our trust? Can you just tell us that?
I think you make a very valid point there, and I think that goes back to my point about these need to be purposeful. So it needs to be driven from our 3-year plan. It needs to be driven from the ICS plan and what we need and where we can get most benefit from those collaborations, and we need to build that work into that frame. I think as far as the improvement collaborative goes, we've had a couple of initial meetings in terms of understanding, so we're in that scoping phase at the moment, Hca, but what we will commit to is actually bringing back 1 or 2 areas specifically that we can then come back and discuss in terms of how we be able to move things forward. I think the Virginia Mason piece and some of those sharing of some of that outputs, and that would be one area. The other is a point prevalence audit, which we're looking to deliver in the spring, which is something that has emerged out of the SWIFT group. It's something they've been doing for the last 7 years that we're looking to adopt here as part of the ICS.
And Chair, if I may just add to Joe's point, Hca, the other area is learning around the admission and attendance avoidance work that the SWIFT group have done. They have integrated community services, so they're perhaps better able to deploy resource into people's homes to stop the ambulance service bringing them into hospital, and we're looking at that model to see how that could be deployed in a situation where integrated community services and acute services aren't integrated, if you know what I mean. So that's 2 areas specifically that we're already working on. But I take your point, we need to be clear on benefits realisation of the relationship, so it's a good point, thanks. Hca, I'll take that back when I have follow-up conversations.
Simon.
Thanks, David. I'm pleased to hear that, because Matthew, that 48-hour rapid intervention initiative that they have in South Warwickshire was mentioned to me by David Raven when I was in urgent care, and so it's certainly something that has visibility in our own services, that people are aware of it, and anything that can reduce the front doors obviously got to be good news. So hopefully that'll come to something.
Okay. Just from a general point, I think this is a really important set of things for us as an organisation. Worcestershire has not always looked outside itself for answers and relationships. And in an organisation in our part, with the challenges that we have, it is often very easy to just concentrate on looking inwards, when actually we know that for most of the solutions for our problems, we need to look outwards. So I think that seems to me, irrespective of what the forms that you have to fill in to send to the centre say, that sort of approach, looking outwards, is a good one. Secondly, this avoids the trap, I think, that many people are going into, which is they're focusing all of their attention on governance and shared committees and all of this sort of thing, which may or may not come out of all this, I have no idea. However, we need to get it. We certainly don't need to focus our attention on that at the moment. What we need to focus our attention on is how we can use these relationships to improve the services for the patients and people of Worcestershire, and I think that's a good approach that we've taken here. In relation to SWIFT, there are good organisation. I don't know what category of performance that they're in, but they're certainly an improving organisation. They've at least got one outstanding hospital in their group. They have district general hospitals, all right, similar to ourselves. Obviously, some of them are smaller, but nevertheless, the similar sort of issues that we're tackling around urgent care, they are already tackling and are thinking about, and we can learn from each other quite a lot. They're a good organisation to work with, in the sense of I've been along to one of their foundation group meetings, and they are genuinely focusing on how can we share good practice. That's the basis behind what they do, and any relationship we have has to have Herefordshire as a big part of it, and of course they run Herefordshire as well. So I think there's I would really commend this work with Swift. I think there's lots of mutual benefits from it, but as Hca has kind of put out extremely well, is that we now need to get down to what are the outcomes that we're going to expect from it, because lots of people chatting together about things is fine, and but actually we really do need to get outcomes of all of that. And it's not a one-way issue. We've lots that other people can learn from as well. So can I confirm that we note the progress? Can we? Well, we've not really considered any additional collaboratives for consideration because we're taking it one step at a time. And we approve the MOU with Swift. That agreed? Thank you very much for that. Let's then move on. Is Paul with us, by the way?
He is indeed, in all his glory.
Excellent. Welcome. I know Paul has been in and out of the meetings because he's been as chief operating officers above firefighting, so he's been doing a bit of that very well as well as anyway. Let's move on then to the integrated the integrated performance report. Vicky.
Thank you, David. Okay, everyone, this is the integrated performance report for month 6, which was September. It's been approved through the Trust Management Executive Committee in October and been through the various subcommittees for assurance. The executive team have identified 4 key areas of focus in the integrated performance report for this month, which is emergency and urgent care, including patient flow and capacity, which we touched on throughout the meeting. The recovery and restoration process for the elective programme across outpatients and diagnostics, workforce, which obviously absolutely critical to all of the above, and there's a section in there around our workforce metrics, and then our financial position across the various aspects, including H1 and H2, the overview of the financial position at month 6, and the capital and cash position as well. In terms of the overall assurance level for this report, it's an assurance level of 4. That has not changed for a number of months. And in terms of individual assurance levels throughout the report, the only one of note that has had any movement on is in the quality and safety section that relates to the sepsis 6 bundle, which has moved from an assurance level of 6 down to an assurance level of 5 due to the non-improvement. Matthew and myself met with exec direct colleagues just to work through over the next couple of months how the IPR report will be enhanced and finessed, just taking back people's feedback that we picked up from various subcommittees and also from Trust Management Executive as well to make it a living document as we know it is. And we also need to do some further work on strengthening our assurance levels when we'll move to the next level of assurance, and that challenge has been rightly put through right the way through from TME all the way through into our subcommittees as well. So that's a work in progress and chairing it. And I'll stop there. Thank you.
Thank you. Okay, so you've identified 4 issues for us to think about it. The recovery and restoration elective programme, first of all. Looking at just as an aside, I think we all have to recognise the enormous operational pressure that the NHS is under at the moment. It is, I've worked in it for 40 years. I've never seen anything like it. Never mind, it's worse than I've seen. It is extraordinary what's what's happening at the moment. And credit to the people who are, keeping the services going, but they're not going in a way that we could ever kind of recognise as being the kind of quality and volume that we would want at the moment. But nevertheless, so all the conversations about performance have to be with that in mind. Having said that, the thing that strikes me, going back to the recovery, and if you look at our operational performance on urgent and emergency care, and you particularly look about how we are doing against our benchmarked other benchmarked organisation, it is actually improving. So in a strange sort of way. I mean, partly it's because I guess some people are getting worse, but nevertheless, we're holding our own. I think I would say I wouldn't defend it or protect it but actually that and the stuff that people are doing, on the other side, of course, on the elective side, it's going in the other direction. I particularly identify cancer as an area of concern here. The 31-day and the 62-day cancer issue. See, we're going in the wrong direction. So, what's happening, and what can we do to make it better? Christine.
One of the contributors to the 62-day performance that we're concerned about is on lung cancer, where we're experiencing a particularly high volume of referrals. We have got a lung cancer GIRFT review coming up on Friday. So that's given us the opportunity to look in a lot of detail at our cancer pathway, and we're sure that we've maximised everything that we can do in terms of pre-investigations. But the fact is that at the moment that once the patients have had their investigations, there is still a wait of up to 6 weeks to see one of our respiratory physicians at the moment. So we're going to be talking to the GIRFT team when they come to see if they've got any ideas how we can improve that. We are out to recruitment for an additional respiratory physician, and if we, I haven't seen in what we've got in terms of applicants, but if we have applicants, then we'll be interviewing on the 2nd of December. We'll also be looking at how we can better use our workforce. Similarly, in one of our other major contributors, which is breast cancer 2-week wait performance, we are looking in more detail at that pathway, and I'm going to visit the breast team in the near future to talk about how we can improve things there.
Thanks, Christine. While you're on, Vicky raised the issue of sepsis, and it's been a constant issue in the board. And from what she was saying, things are going backwards rather than forwards. Is that fair?
I think it depends on what measure you're looking at. So I think in terms of completing all elements of the Sepsis 6 care bundle, we are challenged on that. And the elements that particularly get missed out are recording the lactate in the notes and recording the amount of oxygen that the patient has been given. However, the key outcome measure, which is getting patients started on appropriate antibiotic therapy within an hour, actually we're doing extremely well by comparison to our peers, particularly for patients presenting in the emergency department. And in addition, in terms of, if you look at our mortality from sepsis, then our mortality from sepsis is good.
Yeah, okay, thanks. Paul.
Thanks, Chairman. I just wanted to pick up on the 31-day because, of course, the IPR is only dealing with unvalidated data. So if you look at the validated data for the 31-day standard at 96%, then our confirmed position for the trust in July was 97%, and our confirmed position in August was 91.3%. And compared to colleague trusts across the region, that puts us in the upper performers. So it's just to recognise that the September data is completely unvalidated, but we achieved the 31-day standard in July, and in August we were at 91%.
Thanks, Paul.
And then just to add, I would just on the cancer, just want to draw colleagues' attention that the board were aware that we were running at about 5% for breast 2-week wait, and we'd set a target of getting to 80% in September and to achieve the standard of 93% in October. And just to say, we slightly undershot our target for September and came in at 77%. But we have seen an unexpected further increase in referrals on the breast 2-week wait pathway that's affected us. And if I can just pick up on a broader issue around the elective recovery, as you referred to that, Chairman, then if you look at the position, we can see that for the April to September period, the first 6 months of the year, I think it's notionally referred to as H1 nationally, then our performance against plan for elective work for both new outpatients, follow-up outpatients and inpatient and day case combined was all above plan, with new outpatients being just over 3,500, follow-up outpatients just under 3,000, and elective procedures just under 1,000 above the plan that the board signed off and we submitted for the April to September period. And just to recognise that, as the board is aware, we were successful in the community diagnostic cut wave 1 bid, and to confirm that the whilst we're building the additional endoscopy and CT facility at Kidderminster, in the run-up we also got approval for mobile units so that they could become operational whilst the building work was done, and to confirm that the mobile CT scanner and the mobile endoscopy unit at Kidderminster is now in place and fully operational. And just an added note that we also submitted a bid for a mobile CT and a mobile MRI scanner at the Alex to help improve diagnostic throughput. And Matthew and myself heard on Monday, I think it was, that we have had the approval for that, so we're proceeding with that, which will increase our diagnostic capacity, and clearly that will help also improve our performance on our cancer pathways. And then finally, I just want to kind of note, it does make it is stated in the IPR that the September position for the RTT incomplete waiting list came in at 57,252, and therefore the target set for us nationally is to seek to ensure that the waiting list at the end of March 22 is no greater than the position it was in September 21. So just so the board are formally aware that we will be monitored our overall waiting list size on that figure of 57,252. And at the moment, we're predicting we will come in at about 58,500. So clearly, we're trying to do further work to bring us closer, if not achieve that. So,
thanks, Paul. Thanks, Paul. Anita.
Thanks, Chair. Paul, I mean, yeah, and thanks for this, and absolutely recognise what David was saying, that actually in some ways we're doing better than we would have expected. So that, that absolutely has to be applauded. And clearly the waiting lists generally are what they are, and we know the reasons for that. I guess I always have a slight anxiety because we are measured against these, 52s, 104s, whatever it might happen to be. There is a danger that by trying to work on a metric, we actually don't necessarily treat the most ill patients at the highest acuity. And I wondered how comfortable we were with our ability to assess who are the patients that are deteriorating fastest and therefore who require earlier treatment, because clearly the chronological time on which they get put on the waiting list isn't necessarily the best indication of how sick they are today.
I mean, I think that's true, Anita. If I can just give, I'm going to have to use some horrible language here, but patients are nationally categorised as P2, P3 and P4 on the elective waiting list. P2 are cancer and urgent elective. P3 are kind of viewed as patients who probably need to be treated within 3 months, 12 weeks, and P4 are the non-urgent patients. So in terms of our position is very clear. Whilst we want to drive down the longer waits, we focus in the first instance on the so-called P2 or cancer and urgent elective. So that's where our focus is. But clearly it's on a specialty by specialty basis. So we will treat some patients in one specialty, say who've been waiting 40 weeks, but not in another because of the overall length of each individual specialty waiting list. Secondly, we undertake spot audits of patients that we've treated to make sure that we are treating patients in line with our clear policy, which is urgent first and then chronological. So we're not treating people at, in the middle of the waiting list just because we feel we might like to do those procedures. So we check that we are doing the urgent first and cancer and then chronological. And then thirdly, we undertake triage of the patients on the waiting list, clinical triage, and we've also done a pilot with an automated system with patients to check that those on the waiting list, do they still want to be on the waiting list, need to be, and do they feel there's been any change in the urgency since they were referred. That pilot's gone reasonably well. There's just a couple of issues that emerged about whether patients fully understood one or two of the questions. So we're doing a second pilot to make sure that that's validated, and if that's successful, we intend to roll that out for all patients on our waiting list. So we do a clinical triage, a clinical validation. We cross-check that we are treating urgency and then chronological, but we do it on a specialty basis, and then there are harm reviews as well.
So we are reasonably confident that with those measures, and they sound good, that if somebody was moving from a P3 to a P2 in terms of the acuity of their condition, that we ought to have systems in process that would mean that we could spot that those people, that had happened. Okay, thanks.
Matthew.
Yeah, thanks, Chair. It's a really important question, Anita, and you hopefully remember really right at the kind of early stage of COVID back in 2020 when we were instructed to stop doing elective work. We initiated a process of harm review, as Paul's referred to, because we suspected that that as a consequence of those actions, there would be people that would be waiting longer and therefore experience avoidable harm. And we've continued that process. We are looking again to make sure that is as robust as possible. And with Christine's arrival, we're going to just test again whether that is the right way of approaching the risk of avoidable harm, of waiting longer than any of us would want, and particularly the patients would want. I think the other thing just to mention with the ICS is particularly Ruth Lemiak, who's been appointed as our place level lead, is involved in some work that the region doing at looking at the the impact of people that are waiting a long time for planned surgery, and how many of those end up coming in as an emergency into the hospital. So that's something also that we're engaged in, just to understand what that looks like, because I think there is some emerging evidence, and this is in some ways logical, isn't it, that the shorter the waiting time for planned surgery in any area, the lesser emergency demand for those patients that have become significantly unwell as a consequence of waiting too long. So that's something I think probably into the springtime we'll want to look at progress on.
Simon.
Thank you, David. Just looking at the report, and particularly the first and third bullets of the key issues, if anything, to echo Julie's comment about the perfect 10, show that we have to get some actual product out of the perfect 10. It's those bullet points there. We've got too many people coming through the door who shouldn't be coming through, and the very carefully used wording, require a significant step change around discharges, has been before this board before. And so, Matthew, I know you're working on this, but we are looking hopefully for changes from that perfect 10 so that these issues can be addressed.
Yeah. Christine.
Thank you. Really, it was a similar point to Matthew's, which is that I think the systems that we've put in place in terms of clinical validation of our waiting list, harm reviews, links to urgent admissions are as good as I've seen anywhere else. But that's not to say that they will be perfect, and we do know that patients will come to harm on the waiting list, particularly those patients that we find it difficult to get in touch with, or find it difficult to get in touch with us or their GPs. So it's just to recognise that we're doing the best we can, but the processes aren't perfect, and the only long-term solution is to be able to get our waiting lists down to a level that is much more acceptable than it is now.
Okay, thanks, Christine. Can we talk about the money?
Hi, David. Yes, certainly. So this report at present is very much focused on the half-year position, because obviously that was up to September. We had hoped for the end of the first 6 months to end with a surplus of 1.1 million. There were a number of aspects in the last 3 months, in particular of the first 6 months, where, as we know, we were being impacted by COVID, and there were changes to the ERF funding. So that meant effectively we ended up with a year-to-date deficit at 0.9 million to 1.9 million adrift of where we wanted to be. So that's where we got to in terms of that. We're also being driven by, as we know, the cost of our sickness absence and bank and agency, and the number of hours that we are paying for has remained high for the last few months compared to previous periods. So I think that's really important, that actually we're having to substitute our sickness absence with additional staff just to continue to provide the care that we're doing at the minute. We are also spending more on COVID than we expected to. I think that's partly, again, we talked about the way through, and we know that since September our requirements on our wards and our beds for COVID has continued to increase, hasn't it, Paul? I don't know what the bed numbers are today, I can't remember, sorry. And I think it is possible that we might be actually slightly understating that expenditure, because clearly during last year, when it was the pandemic, virtually everything was a COVID cost for sickness absence in many areas, or stress related. One of the things we're trying to make sure through our teams at the minute is when they are substituting staff who are away, is that we're trying to balance the correct reason for why we've got bank staff in our agency staff, or the sickness absence is there. So people are reporting COVID, but there are, as Tina will pick up, no doubt, additional stress due to the way staff are feeling with all the pressures as well. So that's probably slightly understated, but it is an important aspect. Cash remains good, but that's partly part of the financial regime and the fact that we've been paid in advance and basically been paid for most of what we've been doing. Capital, we're putting a lot of work into, because we've had more capital allocated to us, and indeed additional capital as Paul's managed to secure for things like the community diagnostic hub, all the work around endoscopy, all things that add to particularly the challenges for our estates and project management teams. But one of the things we need to, and we are putting a lot of time and effort into, is Paul's got in base an experienced program director who will hope to bring a level of real discipline into the additional support as well, into the project management and the program management. And we're looking to ensure that we're better able to accurately forecast both the commitments and the work and activity done to date, as well as look for opportunities to improve our position in terms of the programs, or make sure we're aware of any particular impacts or late starts and finishes, for example. That's a summary where we are at month 6. David and I will be talking about the second period in a while in the private session.
Can I just, I've got Hca, but how much did we get through ERF?
We got, I think it was up 3.5 million. I think that's right, isn't it, Paul, for the first 3 months? About 3.5, David. And we're not getting anything.
Just over 3.5 million.
Okay, and that's counted in the numbers for the first 6 months.
It is indeed, yes.
Because one of the issues around the country, certainly people I've spoken to around the country, is that people generated enough money in the first 6 months through ERF then to sort out their financial position for the second 6 months.
Yeah.
We didn't.
No, we didn't. And without going into the history, which Paul could no doubt explain, 1920 was a year we put a huge amount of extra work in to deliver and reduce to 40-week waits at the most. And I think that was, we haven't had that capacity in this year to do anything similar. That we had a real focus in 1920, which is the comparable year. So that's been a real challenge. Paul?
Yeah, but that ERF money that we got could be masking a bigger financial problem in the first 6 months of the year. That's all.
Yes.
Okay. Hca.
Thank you, Chair. My question when I raised the hand, Chair, was it was the point before the money, which was people and culture, but it could relate to money as well, because in the last few months, our staff turnover has been at 10%. And the explanation that's been given is that it's mainly due to, people taking alternative roles in the marketplace. And my question was that, are we not competitive enough, or are we, in terms of our cultures are so bad that people are leaving? I mean, have we done any exit surveys, Tina, to find out why, people are leaving? Because in relating this to money, I think I would imagine that we probably then end up obviously using bank or agencies, perhaps, and that has an effect on obviously on our deficit. But Tina, have we done any exit surveys at all?
Yes, we automatically offer an exit interview for all staff that resign, so then they can choose who to have that exit interview with, if that's a manager, member of the HR, the freedom to speak up, guardian, etc. We also provide them with an exit questionnaire, so if they didn't want to be interviewed, they can fill in the questionnaire with the basic feedback. Main reasons for leaving are it has been in the past retirements. That's changed more recently to flexible working, and hence our focus on flexible working opportunities and improvements going forward. I think we've just seen in general though a change in the national marketplace for jobs, where before there wasn't as many jobs available in other sectors such as retail, etc. And so it's the unregistered workforce where we are seeing an increase in turnover and hence an increase in our vacancy rates for those. We are quite competitive for the unregistered workforce compared to other care providers. So we do offer good terms and conditions in the NHS, but it's the I think level of pressure within the NHS that staff, registered workforce, are choosing to go into work into different sectors. That's the feedback we're getting. And we are doing a focused piece of work across the system look at how we can turn that around by offering people careers through apprenticeships, etc. So step-on-step-off opportunities to receive training. So we need to just reset our strategies and focus about how we can, adopt to the change in marketplace, basically.
Has the results of the exit interviews, the analysis that goes on, has that been to the People and Organisational Development, the People and Culture Committee? Sorry.
Not for about 6 months or so, David. So I can take that through.
I think it should. I think it's an important message there, Julie.
Yeah, I was just going to say we have discussed this, and one of the things that we've found, and I was speaking to somebody, is that things like the hotel sector were deliberately targeting the unprofessionally qualified healthcare staff because they can just pass the costs on, and we can't just raise wages in that way. So we've not had a formal report, but we have discussed it and discussed the exit interviews there. Okay. And I mean, Tina's quite right. What we can do is offer people sort of like enriched job opportunities, if you like, and progression through, because being stuck with national pay grades, we can't compete with hotel and retail sector anymore.
Okay. Matthew.
Yeah, just a very quick point, Chair. Just your colleagues have been on the board for a while. Remember that one of the analysis pieces that we did was looking at establishment versus people in post, and some colleagues will remember that we were over-established with healthcare assistants about 2 years ago. That is one of the big gaps now in terms of vacancy rates for the reasons that Julie and Tina have noted. I think it's also worth noting that our colleagues at St Francis Hospice, St Richard's Hospice, have vacancies at healthcare assistant. For a hospice to have vacancies at healthcare assistant demonstrates the severity of the market change that Tina's referenced. So redoubling our efforts in that space. And for that group, WACOR is very much on the agenda.
Okay. Any other points about the integrated performance report? Okay, so we would note the report. I think on urgent and emergency care, we recognise the effort that's been put into this, but there are two issues I think outstanding. One of them is to get real benefit from the Perfect 10 process that we're going through, to really put everything into that, and also to have much more clarity, public clarity, about what each individual organisation is supposed to be delivering in all of this. On the on recovery. Clearly more work to do here. The ERF is not obviously functioning at all at the moment, and when they in this region looked at it for the next 6 months, they discovered that 8 out of the 11 health systems wouldn't be able to earn any, which seems to me that indicates you've got the rules wrong, because the whole point of it all is to increase it. I think there's a change in policy here where I think the region are going to be allocating money out to organisations to enhance our ability to deliver some of this. So, and I'm sure we are, but we need to get our thinking caps on around about how we can enhance capacity, whether that's between ourselves or the private sector or whatever, to get some of these numbers in a much better place, because behind every number is a patient. The financial position is disappointing. I hope to be somewhere, but we certainly needed to be somewhere better, and that will reflect, I think, where we are the next year. All I would say is that one of our points that we've tried to make is that we've enhanced our ability to control things, and I worry here it indicates that perhaps we're losing our ability to control some things, and that perhaps we're commenting after the event too much rather than preventing something's happened. But no doubt we can have a discussion about that when we get into H2. Capital, absolutely right. This is the amount of capital we're getting is extraordinary, and well done to everybody who's got their bidding caps on. From a period where the trust didn't get much capital at all, we've now got loads, and so as they say in the things, we are the victims of our own success here. But I noticed that you've put in together some proper oversight, capital planning delivery group, which I think Robert's going to chair. Is that
Yeah.
is that right? I understand that.
Yes, Chairman.
So we'll be watching that very, very, very carefully. Thank you very much for all of that. Now we're going to go through the committee quickly through the committee chairs. Although my guess is that I'm going to struggle to find somebody who was at some of these meetings. Just let me get the. All right, committee report. So finance and performance. My two normal characters on this are not here. Are you going to say something, Simon?
Briefly, David, because yes, I was there at the committee. I think this very much relates more to our discussion on H2 that's coming forward, and most of the information will have been reported to you already. So unless there's a particular highlight you want to draw out of there, I think we have the discussion at H2 later on.
Fine, thank you. Quality Governance Committee.
Thank you. The notes are pretty accurate. What we did have was quite a detailed report on services available for patients who present who have been suffering domestic violence, and I think Paula's going to decide when we bring or what we bring to board in the future about that. Everything else is pretty much as the notes say.
Okay, thank you. Thank you very much. Very good, they're noted then. Let's then move on to the nurse staffing report. We've got safest staffing report, adult nursing, and then midwifery.
Thank you, Chair. Thank you. And Justine's on the line to do the maternity one. I just wanted to draw out of the paper that obviously our staff absences did increase in September, and that was through to an increased sickness, both COVID and non-COVID, and household contacts, which then triggered us to do the early enactment of the winter incentive for critical shifts that we know we're unable to fill in the week. So we've enacted that, and we're seeing some reward from that, at least from the 8th of October. And obviously to reiterate around the Hca vacancy and turnover. So the turnover for Hca vacancies for September was 14.57%, working really hard with HEE and local trusts to do recruitment days, hopefully face-to-face, get them in, get them sorted, get them on the wards, and do a 2-day fundamental care programme, and then they can join the care certificate. So I just wanted to bring up that we are absolutely focusing not only on RN but also HCAs, because I've never seen so many vacancies, but also this also links to the decrease in universal credit, where they can absolutely, as Tina's alluded to, go and work in retail for more money than we're paying for Agenda for Change. So that's all I really wanted to draw out, unless there are any questions.
Yes, Anita.
Yeah, this actually probably is a question for Christine rather than Paula, but it was triggered by your report. So Paula, really, really helpful, and it was nice to see some of the support for staff that you have in there. I noticed the professional advocate model that you've introduced, I think, for nurses.
Yeah.
I'm assuming that is that nurses and HCAs or just nurses? And my question for Christine is, do we have, because I don't think we're doing Schwartz rounds, do we have anything similar for medics? And what about other AHPs? Do we have something similar for all patient-facing groups? Is my question. Thanks.
So I'll take the first bit, Anita. And yes, it is across nursing, midwifery, healthcare scientists, allied health professionals, and all line managers are aware of staff support available both internally through HR, Hca Health, and through the PA model as well. And Matthew and I have discussed very briefly about Schwartz rounds and looking at that, and I'm used to that in other organisations, so absolutely. So I hope that's helpful for you from the PA model, and I'll pass over to Christine for the medics.
Yeah, so junior doctors in particular have access to a number of routes of support. So they've got their guardian of safe working and their educational supervisors, and access to the educational faculty who offer pastoral support as well as support with education and training. For senior doctors, we do recognise that they're often more reluctant to access the sources of help that are available. They do access our clinical psychology support, and they also have access to a number of areas of support outside of the organisation as well, aimed particularly at their professional group, so via the BMA and other voluntary sector organisations.
Okay, is that all right, Anita?
I mean, obviously they have got things like Guardians for Safe Working, the junior doctors and so on. I guess it's that restorative supervision, the processing of difficult situations, which I'm sure they faced during COVID, just as the nurses and others have. And I guess that's the piece that seems to be missing from what you've said. So I know you, me and Tina are speaking in a month or so, and maybe that's part of that conversation. Thanks.
Yeah.
Thanks.
Very happy to discuss and very open to looking at ideas of things that have worked elsewhere as well.
Thanks. In the conversation, Paula, you said something like, I can't quite remember the words you used, but something like, there's never been more vacancies, or I've never seen more. Is that right?
The healthcare assistants, yes.
Oh, for healthcare assistants, right.
Yes.
Oh, I referred to them, yeah, okay. Well, when you think, I mean, when we did ICS, I think we identified 3,500 vacancies in health and care across Herefordshire and Worcester. 2,500 of them were the non-professionally qualified.
Yeah.
So this is why we've got a lot to do.
We have
to do this across the system. Okay, thank you. Can we move on to midwifery then?
Yeah, thank you, Chair. So as we expect seasonally, September was a busy month, as was also August, and we now are seeing October is also equally as busy as September. So the impact of COVID on those numbers has had an effect. So we've remained busy, and that has made it difficult to often meet acuity, which you'll see described in the paper. We have had a reduction in fill rates, unfortunately, as well, and it's unclear why that is. We have recently advertised all of our additional funded posts that we've successfully bid for money, both from local authority as well as national, from NHSEI support as well, into posts to increase training and increase retention of newly qualified midwives. So we've had around £800,000, which is really, really great, and also that'll help us to deliver the public health agenda. So some of the good news stories are sickness has remained halved from our previous. It's sitting at the upper end of 6%. But when you remember, historically, we were talking about levels of 14%. We've managed to maintain that over the last 3 months now. 11 people came into post throughout September and at the early part of October, so our vacancies have decreased, and our turnover in the midwifery group is below the trust target. So there's some good news there, and hopefully, whilst this paper offers an assurance level of 4, if we continue with some of these assurances next month, I will hopefully be able to offer an assurance level of 5. Some of the changes that we've made in terms of communication around staffing, on basically due to feedback that we had from our staff before, is we've embedded 3 times daily sit reps and attendance at the bed meeting, and we're working with region at the moment to look at regional escalation plans and how our escalation plans will dovetail into that, and a slightly refined sit rep that is based on that regional piece of guidance, which I'll be attending as a director of midwifery on the regional group to shape that piece of work. So I'm going to stop there and take any questions, please.
Thank you. Any questions on
that? Just one from me, David, if I may.
Yes, that's fine.
Justine, you refer in the report to staff morale a couple of times. How's that going, and how's the improvement plan working, and obviously today's quite an important day with the restarting of the continuity of care consultations and conversations with colleagues. So I'm just interested in morale and what you're doing about it.
So we've had numerous, we're having obviously numerous launch events. They were fairly well attended. Paula and I attended a feedback session for staff based on the previous engagement events, and I think some of the conversation is certainly changing, and the focus on continuity is not quite where it was before. I think, you know, there's a way to go, Simon, to be honest. You know, people are still incredibly busy. While sickness is down, our other absence related to COVID is still present, and that puts additional pressure on our teams every day. So we are still seeing, you know, delays in our induction of labour pathway, and that is not great for our mums, and obviously that also adds additional pressure to our teams because they're providing additional care for longer to women, and also trying to address some of their fears and concerns about their care being delayed longer than we would like it to be, and their patient experience is reduced. So whilst they're positive about seeing some of our, you know, new starters, and they're very cited on our plans, I think all we can say is that people are reporting that they can see that things are slowly getting better, and I think that's as much as I could say today.
So that I understand, you know, the point you made about the induction programs. I hadn't picked up anywhere that they were not recovering, that there was a problem with them. Is there somewhere in the papers here that I've missed that we know that, or is that just assumed by everybody?
So it's picked up in the paper in terms of the red flags and the incident reports. And what we had noted, it was one of the things, Chair, that hadn't been well reported before. So we put a process in place so that I'm cited on the lists of women who are delayed on a daily basis. Yeah. And that will also form part of the SIP rep now, so you can see how many people are delayed and for how long. Talking to colleagues across the whole of the Midlands, they are experiencing similar issues. Because it is the elective work that we're able to control a little bit, and obviously when we've got internal pressures, that is something that we unfortunately have to do to maintain safety.
Okay, Christine.
Yeah, it was on continuity of carers, and I wondered whether the midwives might have the opportunity to hear that lovely patient story we heard this morning, because we know, don't we, that patient stories are powerful in terms of influencing clinical staff, and it was such a wonderful story. It'd be lovely if they got to hear it.
Yeah, and there have been numerous patient stories before, Christine, and a video actually of a number of women talking about their experience that have been shared with staff. But I have to say, I think Rosie put so much into that story that was really, really insightful, and talked, and you know, all the evidence that underpins this model of care she drew out in her conversation in terms of women at risk and how they're more likely to share that information. You could hear the relationship that the women are creating with their midwives, and how that impacts on their decision making about their care. I mean, it was just superb, wasn't it, how she was able to frame it all. So I think it's a really, really great example, and absolutely we'll be able to share that.
Okay, thanks for all that. So we note the safest staffing report for nursing, and we note the safest staffing report for midwifery. Thanks, Paula and Justine.
Thank you.
Okay, let's then move on to the responsible officer appointment. Rebecca.
Yes, Chair. A paper purely for the record, just to confirm Christine's appointment under the appropriate regulations. There's a quirk in the regs that mean that we need to actually tell you, even though she's been obviously appointed as Chief Medical Officer. So it's for the record. Thank you.
Okay, I'm sure somebody at some stage will tell us what all that means. Okay, thanks.
You have to approve that I'm a fit and proper person to be the responsible officer for the organisation.
Oh, I don't know about. Yeah, sorry, no. Absolutely right. Absolutely.
Yeah, I have completed all the training and I have done it before. So.
Good. So can we approve that? Yes. Thank you very much. Right. Any other business? We didn't have any. Date of next meeting, the 9th of December. We now bring the meeting to an end. We'll reconvene in private at 12:45. Thank you very much for attending.